Good afternoon. Today we're going to study peripheral artery disease or peripheral vascular disease. PAD, which is also called, is arteriosclerosis of the extremities. Virtually is always in the lower legs that causes ischemia. It's an abnormal thickening and also a loss of elasticity in the arterial walls. Peripheral artery disease could be divided into a mild peripheral artery disease that most of the time is asymptomatic, or it could go up to moderate and severe, causing intermittent claudication. Sometimes severe peripheral artery disease may cause rest, pain with skin atrophy, hair loss, cyanosis, ischemic ulcers, as well as gangrene. We're going to discuss briefly pathophysiology as well as the etiology of the disease. Basically, as I previously said, is the thickening of the arterial wall outside of the heart and the brain. So basically, it's not related to the coronary arteries, and it's not related to any arteries in the systemic or the central nervous system. This thickening are called plaques, and that is created by arteriosclerosis. The etiology, most of the time, is produced by increased age, hypertension, diabetes, dyslipidemia, smoking, which is one of the most prevalent risk factors, as well as male sex and high levels of homocysteine. But again, 50 to 75% of patients with peripheral artery disease have arteriosclerosis. So the most common and most important etiology of peripheral artery disease is arteriosclerosis. It could become, as I said, from mild to severe, decreasing the blood supply and nutrients that go to the leg muscles. This is basically statistics that affects 8 to 10 million people in the United States alone. 12 to 20% of adults over age of 65 and more than 20% over age of 75. Even though it could also affect women, it's more common in men. And 75% of people do not have any clear-cut symptoms of peripheral artery disease when it's mild. This is again talking about the prior risk factors that we already discussed: smoking, diabetes, hyperlipidemia, hypertension, age over 50, and even greater incidence over 70 years old, any family history of prior peripheral artery disease, any cardiovascular disease or prior stroke in the family, any intermittent claudication, which is the most relevant and most common symptoms for this disease. Patients most of the time complain that while they're walking, they have to stop due to pain. Any prior history of C.A.D. or angina, angioplasty, bypass, using the Venous for graft, or any prior stroke. What are the most common signs and symptoms? Again, typically, peripheral artery disease causes intermittent claudication, which is painful, aching, cramping, uncomfortable, or tired feeling in the legs that occurs during walking and is relieved by rest. Claudication usually occurs in the calves, but can occur in the feet, in the thighs, hips, buttocks, and even arms, even though the most common presentation is in the legs. Claudication is a manifestation of exercise-induced reversible ischemia. It's very similar when the patient has angina pectoris. that is induced by exercise and relieved by rest. As peripheral artery disease progresses, the distance that can be walked without symptoms may decrease, and patients with severe peripheral artery disease may experience pain even at rest when it's severe, and that reflects irreversible ischemia. Rest pain is usually worse distally and is aggravated by leg elevation, often causing pain at night as well. And this is here very difficult to distinguish from restless leg syndrome. When the patients place the legs below the heart level, the pain lessens. The pain could also be manifested as neuropathic pain, such as burning, tightening, or nociceptive, such as aching. Like 20% of patients are asymptomatic when it's mild, sometimes because they're not active enough to trigger leg ischemia. Some patients have atypical symptoms, such as non-specific exercise intolerance. They believe it's because they're old or because they're obese, or some other patients have hip or joint pains. Again, mild peripheral artery disease sometimes have no symptoms at all, and moderate to severe peripheral artery disease commonly causes diminished or absent peripheral pulses, such as popliteal, tibial posterior, dorsalis pedis, etc. If you do a Doppler ultrasonography on these patients, can often detect the blood flow that is compromised when the pulses cannot be palpated. But at least you could hear the pulses through Doppler. Below heart level, the food may appear dusky red, and that's called dependent rubor, very typical for this disease. In some patients, elevating the food causes loss of color and worsens ischemic pain. When the food is lowered, venous filling is prolonged, more than 15 seconds, producing these changes in color. Edema is usually not present unless the patient has kept the leg immobile and independent position to relieve the pain. Again, foot or leg pain at rest that works with exertion. Non-healing foot or toe wounds, those are ischemic ulcers. Discoloration of the feet, dependent rubor, and sometimes in extreme cases, in severe cases, patients could even develop gangrene due to ischemia. As ischemia worsens, ulcers appear, especially after local trauma. The ulcers tends to be surrounded by black necrotic tissue, and that's called dry gangrene if you remember in pathophysiology. Dry gangrene. They're usually painful, but people with peripheral neuropathy due to diabetes or alcoholism may not feel the pain of these ulcers. Could be infection superimposed to these ischemic ulcers, developing wet gangrene, and even could progressively complicate with cellulitis. The level of arterial occlusion influences location of symptoms. For example, if the patient has peripheral artery disease in the aortoiliac area, may cause buttock pain or thigh pain or calf claudication. Sometimes patients could develop peripheral artery disease at the level of the sacral area, and that could cause erectile dysfunction. Again, some patients have no symptoms whatsoever when they are mild, and some others could have leg cramping, leg or hip fatigue, heaviness, or discomfort in the thighs, calves, or hips during activity. Other physical findings, as I previously stated, dependent rubor. Because of ischemia, the skin will be shiny and hairless, pallor, cyanosis, ulcerations, and even reduced pulses that could only be heard with Doppler. Now, how do you diagnose this disease? Well, the most important diagnosis is ankle brachial blood pressure index. It could be due also by ultrasonography or angiography before surgery. People with peripheral artery disease are likely to have fatty buildup in other arteries as well. And there's 6 to 7 times higher risk for heart attack or stroke. Physical examination, if patients, of course, complain of pain while walking, that they have to stop, otherwise the pain is excruciating, that's an indication of peripheral artery disease with the prior mentioned risk factors. Ankle brachial index is one of the most common and initial diagnostic evaluations for this disease. Basically, what you do is you take the blood pressure in the legs and in the upper extremities. So basically, ankle and brachial. Normally, the blood pressure in the ankle is at least 90% of the blood pressure in the arm, and blockage in the legs would cause this to be reduced. So how do you interpret that? It's basically by an index or ratio. A low or less than 0.90 ankle brachial index, which is the ratio of ankle to arm systolic blood pressure, indicates peripheral artery disease. And that could be classified as mild when the ankle brachial index is from 0.71 to 0.90, moderate from 0.41 to 0.70, and severe when it's less or equal to 0.40. If the index is normal, then the systolic blood pressure ratio ankle to brachial would be from 0.91 to 1.30. But suspicious of peripheral artery disease remains high. The index is determined after exercise stress testing. So if you do brachial ankle index ratio, and even though the values are normal and you still have high clinical suspicions of peripheral artery disease, you could go ahead and do the same testing after exercise stress test. A high index of more than 1.30 may indicate non-compressible leg vessels, and that could occur when the arterial wall of the legs are calcified by arteriosclerosis, but not necessarily indicates that a patient has peripheral artery disease. Additional testing that could be done, Doppler ultrasonography, measurement of blood pressure in the first toe using a toe cuff, but that's not commonly done. In addition, you could do angiography, and that provides detail of the location and extension of the arterial stenosis, and as actually a prerequisite for surgical correction or percutaneous transluminal angioplasty or PTA. It is not a substitute for non-invasive testing because it provides no information about the functional significance of abnormal findings. An MRI or magnetic resonance angiography or CT angiography or non-invasive test that may eventually supplant contrast angiography. So basically, the most common and initial test that should be done and you will be tested on is the ankle brachial index. Now, the most definitive test, the most common and initial test will be ankle brachial index, and the most definitive test will be arteriogram. Now, in addition to diagnostic evaluations, we already went over the risk factors, and treatment should be concentrating in eliminating the risk factors. Of course, because the most common cause of peripheral artery disease will be atherosclerosis, you have to target your treatment on atherosclerosis. So patients must be on lipid lowering drugs, such as the statins, if they're not contraindicated. So you must have reviewed already the guidelines for ATP3 and the updates. So you need to basically concentrate on lowering lipids. And even though the LDL is not elevated, patient must be on lipid lowering medications. Also, you have to concentrate on the risk factors. Smoking cessation is one of the major risk factors, and quitting smoking is very important part of treatment. Diabetes, try to control blood sugar, also high blood pressure, which is the best antihypertensive medication for peripheral artery disease if it's not contraindicated, ACE inhibitors. Even though claudication uh, is produced by exercise, you do not stop exercising. You have to, on the contrary, tell the patient to continue walking. Diet, because another risk factor is hyperlipidemia and high cholesterol. Try to eliminate saturated fats, and again, anti-lipidemic medications. So lifestyle modification is very important before we go into the actual medications. Exercise programs, typically 30 to 45 minutes, 3 to 4 times per week. Diet low in saturated fat, trans fat, and cholesterol. If you could put the patient in dietitian consult for better management. Now, medication-wise, antiplatelet drugs such as aspirin and Plavix. In addition, you could start Trentol and Pletal, Cilostazol. Cholesterol medications such as statin. Basically, these two medications are for the ischemic process and can help reduce the symptoms on these patients. All patients that require aggressive risk factor modification, including, again, smoking cessation, control of diabetes, dyslipidemia, hypertension. Remember that hyperhomocystinemia is the risk factor, so you could try to control that. Vitamin C, beta blockers you could also use, and they're safe unless peripheral artery disease is very severe. If it's very severe, then it's contraindicated. Again, exercise 30 to 50 minutes or 45 minutes on the treadmill, or track walking in an exercise test pattern 3 to 4 times per week. As I already said it, you could do also supervised exercise programs with training that can increase symptom-free walking distances and improve quality of life. Mechanism probably include increased collateral circulation, improve endothelial function with microvascular vasodilation and decreased blood viscosity. In addition, exercise improves red blood cells filterability through the vessel, decreases ischemia, decreases inflammation, and improves oxygen extraction by the arteries. Patients are advised to keep the legs below heart level. For pain relief at night, the head of the bed can be elevated about 10 to 15 centimeters or 4 to 5 inches to improve blood flow to the feet. Patients are also advised to avoid cold or drugs that could cause vasoconstriction, such as any over-the-counter flu remedies that uses pseudoephedrine. In addition, don't forget about food care is very crucial for patients that have diabetes, including daily food inspection, podiatry consultation, daily washing of the feet with warm water and mild soap, I'm sorry, followed by gentle drying, and avoid any type of high chemical or thermal uh, changes like very hot water, etc. Try to avoid poorly fitting footwear. Antiplatelet drugs, as I previously stated, you could use, for example, aspirin 81 milligram. You could use dipyridamole 200 milligrams PO once a day, Plavix 75 milligrams once a day, Ticlet or Ticlet, TICALID 22, I'm sorry, 250 milligrams twice a day as well. For relief of claudication, you could use again pentoxifylline 400 milligrams TID with meals and cilostazol. And that's basically to relieve intermittent claudication by improving blood flow and enhancing tissue oxygenation in the affected areas. These drugs, pentoxifylline and cilostazol, are not substitute of risk factor modifications and exercise. Actually, pentoxifylline is being controversial because the effectiveness is kind of like mixed. It has been trials that the intermittent claudication is not improved and could cause headache and diarrhea, and is also contraindicated in patients that have severe heart failure, congestive heart failure. ACE inhibitors have several beneficial effects. First, they are anti-atherogenic. I don't know if you knew that, because they promote degradation of bradykinin. I don't know if you remember that in pathophysiology, and the release of nitric oxide. So they're also potent vasodilators. You could use the ramipril. It's actually a recent randomized trial that shows high significant improvement of claudication. Arginine, vasopressin, has been in trial but is not approved yet. Now, other treatments that could be used before surgery, percutaneous transluminal intervention or PTA, and of course, angioplasty or thromboendarterectomy. Balloon angioplasty as well as stent, and there is actually a diagram showing the stenosis and how it dilated after placement of the stent and a balloon. In addition to revascularization, of course, if the patient undergoes a necrosis and gangrene, amputation is another choice. But chronic venous insufficiency is basically an impaired venous return due to destruction of the valves that could cause deep thrombophlebitis and elevation of venous pressure, as in CHF. Causes, again, same as the peripheral artery disease, is very common in women, and it could be also genetically predisposed. Patients tend to have a history of leg trauma and is associated with varicose veins. The signs and symptoms are basically the same. They have aching of lower extremities relieved by elevation, and edema with prolonged standing, and they complain of leg cramps at night as well. Physical examination, if you look, is more or less the same. They have trophic changes, stasis leg ulcers, edema of lower extremities, dermatitis, most likely with hyperpigmentation, and cool extremities. The diagnosis, again, could be done by ankle brachial index and by clinical signs and symptoms as well. The treatment, as before, leg elevation, support horses, weight reduction because obesity is one of the risk factors, and treat the dermatitis and the ulcers as well. But thank you very much. This was the presentation for peripheral vascular disease. I hope you had enjoyed it.